Okay guys, so this is going to be a video that is going to introduce the initial application of non-invasive positive pressure. I did another video that talks about circuit setup as well as confirming some of the things like a leak port, a mask elbow, and things like that in the back menu. So this would be after we've confirmed the patient has an indication for non-invasive positive pressure, or BiPAP in this case. We've made sure they meet criteria. We're trying to either fix an impending respiratory failure, an active respiratory acidosis, something along those lines. And then we're going to go ahead and initiate here. So I'm going to talk about some initial settings. Some of the screen is a little bit blurry on my webcam here, so I'm going to do my best to kind of point stuff out. All right, the circuit is already completed. I'm going to show you how to kind of select a mask. So every mask is a little bit different. So most of them are going to come with their own little sizing guides. Some of these are cut into the actual packaging of the mask. Some places that you'll have like a laminated card. With the current Philips Respironics mask, they give you this paper piece that's inside of the mask or your interface bag, and then all you have the ability to size for a full face mask, so covering the nose and the mouth. And these are a very useful sizing guide for what we call an under nose cushion. So if you got a patient with tissue breakdown, or having some pressure injuries from maybe having to wear this too long or having very, very thin skin, you can switch using the same headgear. You can switch over to a oral nasal mask, so it still covers nose and mouth, except it doesn't put that pressure on the bridge of the nose, which is the most common state for breakdown. What I'm going to do, I'm going to hold this sizing guide up, okay, and it shows you we're going to try and go from the top of the bridge of the nose pretty much down to this little cleft of the chin, okay? You don't want it too close to the lip, you don't want it proceeding kind of down and past. In real life, we're going to end up kind of doing more of an estimate on something like this, because I don't want to just stick this onto this patient's face and then, oh, that didn't work, all right? So a lot of times we're holding something up, and with time you do get pretty proficient with whatever your masks are. So he'd probably already be on an oxygen device or something, so I'd be kind of moving that out of the way just a smidge. All right, this guy's size is large, so I'm looking at that cleft of the chin up to the top of the bridge of the nose. If you choose too large of a mask, you're just going to have more problems with leaks, and you're going to end up having to tighten it down, making them more at risk for pressure injury. If you use too small, you're just not going to have a good fit. It's going to be uncomfortable. Their lips going to be popping out, and all these different sorts of things here. All right. So I've chosen my mask. All right, I got everything all set up and ready to go. The one thing I would recommend, and I would add this on just because it's going to be part of our competency, if you're getting ready to do a nebulizer after initiating, you would want to think about placement. Remember to get optimal deposition of your patient. For a single limb circuit, we do need to place the nebulizer distal to this exhalation port right here. All right. If you had a vibrating mesh, so an Aerogen, that would be the best way. Some of these masks actually do have a little spot in the top here of the mask where you can actually, if you have the proper adapter, you can actually put in an Aerogen right into the top of that. You could also use a valve T-piece, okay, but that connection needs to be past this, so distal to the exhalation port and proximal to the patient's mask. It does add on dead space, so if you're having problems or concerns about that, you don't necessarily have to leave it in line all the time, but it's important to know where to optimally place that. All right, putting it back here at the machine makes it very convenient for us, but not very effective for your patient. So I have the proper mask selected here, okay? I am going with a large on this patient. What I recommend is getting all these straps nice and loose. There's ultimately 4 different connection points that happen to the mask, to this headgear. There's 2 up top and 2 down low, all right? We got the quick release straps here that you want to fully utilize, and we'll talk about those here a little bit later on. But what you're going to find yourself doing is you're going to be doing a lot of different things one-handed, and it's far easier to hold the mask on one-handed and make changes and make one-handed kind of changes with tightening straps than it is to loosen them. Just my kind of clinical experience there. All right, so I like to get these straps nice and loose, make sure I got the appropriate mask. All right, this patient would already be on their oxygen device, so I wouldn't take them off and then drag my feet and be slow and take away their support. Let's talk about initial settings here, and it's going to be a little bit tough. I'm going to try and bring this a little bit closer. All right, so we have no idea what settings this patient is going to need, okay? People can order 10/5 all day long, but at the end of the day, I need to be there and see what's going on with that patient. We'll talk about titration here in a little bit. The only 2 things we can really come up with and know concrete or have a better idea about initial application will be your baseline pressure, so, and once again, it's blurry, I know, so our EPAP, all right, and our FiO2. We'd have to think about what's going on with this patient, and that would help us better come up with an informed decision for those 2 selections, all right? When in doubt, You're better off to start the high FiO2, or if you don't know a lot about the patient, starting them at 100 and quickly weaning down once you get them stabilized, all right? But if you have somebody with accurate pulse oximetry readings and they're on a current oxygen device, you can kind of make some inferences and guesstimates, okay? If we had somebody that saturation's okay on a non-rebreather, but they're just going on BiPAP for work of breathing issues, or to transition, we think they got a decent amount of shunting going on, we could consider that FiO2 on a non-rebreather like 60 to 80%, and we could maybe use 80 or 60 as a starting point and kind of go from there. EPAP, so the thing to keep in mind is a single limb circuit. It creates pressure by constantly pushing flow through, right? And it's measuring that pressure achieved right here at this exhalation port, this proximal pressure line. You can't go any lower than 4 centimeters of water, okay? And the reason being, if you had to set any lower, there wouldn't be enough baseline flow to flush out CO2. So 4 would be the utmost lowest. You'll see a lot of people just start with 10 and 5 and generically. 5 is typically okay for an expiratory pressure, 4 or 5. If you got somebody who's maybe got a little bit of auto PEEP, COPD exacerbation causing issues, a little bit of marginal oxygenation. When we have somebody with significant shunting and a significant oxygenation problem, or somebody like with congestive heart failure exacerbation and terrible refractory hypoxemia, once again, those would be situations in which I'd maybe want to start with a little higher elevated baseline, maybe at 8, 10, 12 centimeters of water, depending on what's going on. Aside from that, or only initial settings, I don't know how much pressure support my patient's going to need. Once again, IPAP minus EPAP, or your inspiratory minus your expiratory, is the true amount of assistance you're giving that patient on inspiration. I typically start out with 4 or 5 centimeters of water as a rough baseline. We're not trying to scare the patient, okay? But we need to know how to quickly adjust that level of pressure support to achieve some clinical goals that should be attained at the bedside. Putting your patient just on 10 and 5 and leaving them on that for 30 minutes or an hour and getting a blood gas after when they look terrible and you're not reaching these certain clinical goals, that would be inappropriate, all right? So I start low, but I need to know how to read this machine and how to make proper changes moving forward. So right now I'm going to start with an IPAP at 10, EPAP at 5. So 5 is support. We're going to start with 100% FiO2 here. Respiratory rate, this is a backup rate, so you want to make sure you're in the right mode. Most of the time you're going to be starting with spontaneous time, which is, gives us the ability to set a backup rate, but mainly spontaneous ventilation. This respiratory rate should never really play a part unless the patient has trouble triggering, so a leak, they died, auto PEEP, something along those lines. It's meant as a backup so we can make adjustments. We don't use this like an invasive ventilator typically in making rate changes to fix somebody's work of breathing or blood gas or something like that. So there will be other situations where we'll be setting in CPAP or maybe AVAPs or pressure control, okay, and those all play a part in certain aspects and have the benefits and disadvantages and things like that. Right now we're focused on spontaneous time. I usually set a rate at 10, something low and back up, give my patient a 6-second buffer where if they don't trigger it's going to kick in, but not high enough where it's going to interfere with their active breathing. I time is not going to do anything unless a time-triggered breath is taking place or one of these rate breaths, so it doesn't really matter, but it's not going to typically kick in, but you do want to make sure you have it set appropriate in case something does happen and they can't trigger. 1 second's a pretty good I time for most adults in pressure ventilation. 0.8 to 1 second would be a good setting. I usually leave that at 1. Rise time is how quickly or how aggressively you reach your set pressure, so this is going to have a direct relation with how aggressive your flow delivery is. It's just an arbitrary setting, 1 through 5, but it gives you a little graphic. Most patients with a work of breathing or air hunger, we want to reach that pressure really quickly, give them a big burst of flow when they start the breath to fully support them, so generally 1 or 2. I honestly, unless you're doing this for like sleep time, nocturnal hypoventilation kind of stuff, I don't find myself using that gentle rise very often. 1 or 2 is a good starting point. As you learn more about ventilator graphics, you can further refine that later on. So I'm going to go ahead and accept. Ramp, we don't really use in acute settings. Ramp is pertaining to the EPAP. If you had somebody with a really high baseline and you wanted to start them out low and work your way up, you could use that. Might be okay for sleep time maintenance, but for acute care issues, we usually don't set that. So I initially like to have my alarms kind of buffered out, but I do set them afterwards. It's important to know how to silence this here, okay? So this machine, as soon as it senses an occlusion on this patient's face, it should start up. But you want to make sure, because if something is improperly connected, it may not, or if you don't get a good seal. So always a good rule of thumb to make sure gas is coming out of that device, all right, and you're actually in full-on ventilation. So I'm going to go ahead and I'm going to apply it on the face, but once again, you could always hit restart if you're concerned about that. What I'm going to do is explain kind of how this is going to work for this patient. I'm going to hold this up to their face and kind of let them get accustomed to it, all right? At the bedside, I maybe be actually holding the mask on and quickly making changes to their settings before I strap them in. But for the sake of simplicity for this video, I am going to get them strapped in, and then we'll talk about adjustments and stuff after the fact. I'm using an ASL 5000 lung simulator, so I will need to be able to get back to my screen and make some adjustments that can't be taken care of on themselves as we make changes. All right, buddy, so Blake from Respiratory, I'm going to go ahead. You're having some trouble breathing here. We're going to try and get you a little bit more comfortable, get you breathing a little bit better. I have something called BiPAP. It's a tighter fitting mask. It's going to help force air into and out of your lungs, okay? It's going to help you feel a little bit more comfortable, hopefully. It is a tighter fitting mask, all right? So what I'm going to do, I'm going to kind of hold this mask up to your face, let you get kind of used to it. All you got to do is really start the breath and let the machine do most of the work, okay? So start that breath and let that thing kind of push some air into your lungs. I am going to make your settings much more comfortable once I get you strapped in. I'm just going to let you get used to this, and I'll kind of get you quickly all tucked in here and get you feeling better, okay? So once again, I'm going to go ahead and apply this to their face. What we're trying to do is make a good seal. The triangle part should seat up on the top bridge of the nose. And I'm going to go ahead and I'm going to kind of seat this. If you don't have a good seal, all right, it's not going to start up. Likewise, this machine is trying to measure the baseline leak to be able to effectively notice when a patient's trying to trigger, all right? If you don't have a good seal, your volumes are going to be inaccurate, and your patient may not be able to trigger here, okay? I'm looking at my patient leak. If you see PT leak instead of TOT leak, that means that I did confirm, or somebody did look back and set the appropriate leak port or your exhalation port setting, or tested it, as well as confirmed the possible leak port on your mask, and that only is applicable to the Philips Respironics stuff. So I do look at leak, but I'm also looking at my patient's face. All right, you feeling okay? I'm kind of letting them get used to this. Clinically, I'd be making changes to their settings because this guy's breathing 36 times a minute and very suboptimal tidal volumes. All right, I am going to get him strapped in for the sake of this video, and then we'll talk about making some changes here. Okay, you can see just me briefly letting my hand off the mask for a second. Our tidal volumes falsely elevated, and our respiratory rate dropped down. Okay, that's all inaccurate. You want to give yourself several moments to make sure values are stabilizing before you jump the gun. Okay, I'm looking at leak. Ideally, if we can get a leak 20 to 30, that's great. As I start getting up above 60, I get concerned about that. And likewise, I want to make sure I'm able to reach my peak inspiratory pressure that's set, which we are right now. I'll further kind of refine this leak here in a minute. Okay, we do want some sort of a leak. If you have zero leak, you got that strap too tight, and we're gonna have some problems here. All right, buddy. So I have those straps all nice and loose here. I would have this patient in an upright setting. I can't do it with the ASL 5000 here. All right, and that just makes it a little bit easier for them to breathe while we're doing this. It also makes it easier for application. I want to make sure my straps are not all twisted. What I want to do, the first order of business, the most important part of the connections is going to be these lower portions, okay? Once you get these lower portions squared away, you're going to have a pretty good seal. So we're going to start. I'm holding my mask where I like it, centered on the face, okay, not smushing anything, got a decent leak, and clinically I want to be able to see my machine a little bit better. I'm putting these quick release tabs on, and then all I'm doing, and I try and kind of avoid being on top of the ears and stuff, all I'm doing is holding one hand on the mask, and I'm pulling the slack out with these little Velcro tabs to try and hold my work in place. Okay, so I did that down low. I'm going to go ahead and do everything kind of up top here. Making sure my mask doesn't get all crazy. And then I'm kind of looking, listening, and feeling for leaks. I look up here, I got a total leak of 33, okay? I still want to make sure it's not spraying him in the eyes or anything like that. It looks like a pretty good seal on him, all right? Not having any excessive leaking. I can't feel anything spraying him in the eyes or anything like that, all right? So I'm going to go ahead and I'm going to use this last little strap that just kind of tightens everything up over the top part crown of the head. That feel okay? Not too tight or anything? All right, good deal. Okay, so let's talk about settings and bedside goals. So I have an appropriate leak here right now. It's not spraying him in the eyes or anything like that. Right now, I'd be looking at their pulse oximetry to make sure my EPAP and FiO2 are appropriately set. I'm already on 100%. Okay, once again, I know this is really blurry. I'm already at 100% in EPAP of 5, so why would I go up on my EPAP? Well, at the bedside, right after initiation, that would be if I couldn't reach my oxygenation goal. I'd consider going up on an increased baseline, making sure it's not a tension pneumothorax or something causing problems. That'd be a absolute contraindication of this type of therapy. So right now, if my saturations are okay, I can look at trying to wean that down, okay? Right now I'm giving 5 centimeters of pressure support. And what are our goals? So pressure support, or the difference between our inspiratory pressure and expiratory, is the amount of inspiratory assistance, or the amount of work that ventilator is applying to this patient's respiratory system. That level of pressure support is going to be responsible for our tidal volume here. It's going to be responsible for our patient's work of breathing, and our goal is to make this patient comfortable, okay? Our goal is to give them a little bit deeper breaths, and if they can breathe deeper, okay, each of those breaths is going to be participating in more alveolar ventilation, and they're not going to have to breathe so fast when things go well, at least, okay? So right now this guy's breathing 36. His tidal volume is 210 milliliters. He is not receiving an appropriate amount of pressure support. So I don't like to generalize, okay? Really, the goal with BiPAP is to deliver not huge breaths, just kind of more seemingly normal breaths, but let the machine do most of the work. Ideally, we're liking to try and shoot for about a 6 mil per kilo tidal volume when we are initiating ventilation. All right. Sometimes we don't know that patient's height right away. All right. Sometimes we're in the middle of stuff and just trying to get them squared away. So to generalize, I'd say most of our adult patients that are normal sized, okay, we'd like to see them well above 300 milliliters, okay, as we start getting up on really tall patients up in the 400s and things like that. So if you can get a tidal volume around that 350 to 400 mils, that should be safe and appropriate for most adult patients. And then we can kind of refine depending on what's going on with those settings and how big they are and things like that. So right now our tidal, so let's say this guy is 70 kilograms, okay, 70 kilos. If we're trying to give him 6 mils per kilo, 70 times 6 would be 420 mils. So that should be our goal tidal volume here, okay? Honestly, at the bedside, that is one thing, but we also want to see our patient's respiratory rate ideally less than 30, okay? It's not going to be normal, but if we can get him to drop down below 30, that's great. If we can get work of breathing looking good, or at least improved, that's ideal, all right? And we need to change pressure support to be able to achieve that, all right? So right now, I'm going to reset my alarm so you can see all my graphics here. All I'm going to do is kind of go up on my inspiratory pressure just a little bit, okay? And I'm going to give it a few seconds, and I'm going to watch and look at my tidal volume here, okay? So it went up a little bit, and with clinical experience, you'll be a little bit more comfortable on how quick to jump. Okay, I'm going to go up to 15. So now I'm giving tennis support. I've increased my pressure support twofold here. You can see my tidal volumes are starting to improve. I'm going to make a couple of adjustments on my lung model here at the ASL. As this patient's tidal volume would begin to improve, you should see their work of breathing improving. You should be seeing their spontaneous rate hopefully dropping down. Now keep in mind, we do need to reevaluate our leak as we increase this pressure. More pressure in the system, more likely to push air out. So I'm still in an appropriate leak value, but if I could kind of snug this mask up a little bit, what I'm going to do, there's a little fine-tuning adjustment knob that kind of puts a little bit more pressure on the bridge of the nose. I'm going to hit that button and just make a little bit of a better seal and see if that brings that down some. Actually made it a little bit worse. Go back to where it is. I'm going to tighten these lower straps just a smidge. Okay, once again, that leak would be tolerable still, okay? But I like to try and be around that kind of 30 liter. Okay, you can see for a second our tidal volume's got a little bit crazy. I'm going to give it a second, all right, while everything kind of equilibrates. Once again, it's trying to assess that baseline leak. So I had a little bit of a big mask leak there. Okay, it made my values jump up really high. And just give it a second before you start freaking, okay? So I'm getting better. Respiratory rate's coming down. I'm closer to that 420 mil goal that I'm trying to get to. So that's right up here, 335, rate of 33, leak's still okay, all right? You can see these are all spontaneous breaths, so the respiratory rate's never kicking in. The eye time has nothing to do with any of the breaths this patient is currently getting for the most part, okay? I'm gonna go up a little bit more. So usually going up by 2 or 3, asking the patient if that feels better. Don't forget about the patient here. I'm giving you a little bit more help here, buddy. Okay, as that tidal volume improves, we would expect to see that patient's respiratory rate improve. Once again, watching the leak. So let's see. I'd be looking at my patient. The work of breathing is better, okay, or he looks improved from when I first initiated. Hopefully you can give me a thumbs up and tell me you're feeling better and can kind of confirm that. I'm reaching about 450 mils, something like that, which once again, 420 is a loose guideline. We're just trying to get somewhere close. It's not going to be exact. It's going to jump around. That's appropriate. It's not going to hurt anything, okay? We're 30 mils over. Because we're giving more effective alveolar ventilation, his rate came down below 30, which is our goal. So we're reaching his tidal volume goal, all right, 6 mils. We're reaching his respiratory rate goal and work of breathing goal. We'd be happy with this. We continue to monitor, give him a little bit of time. I really like transcutaneous CO2 monitoring for initiation of non-invasive ventilation. Capnography, not that we couldn't put nasal cannula on this guy to measure CO2 or something like that. But there's so much base flow. I don't necessarily trust those values that we're getting for a lot of our patients. Transcutaneous is a very good option for these patients if your facility has this or has that. Okay, a lot of places maybe only are using those if you have more of a pediatric population, but it's very valuable in adults. Okay, so we need to make sure we're monitoring them. You know, we already see an improvement, but ideally we see improvement in 30 minutes. Some patients need a little bit more time. If they're showing worsening, okay, and we got to make some setting changes, that's great. But if they're moving in the wrong direction, the decision to intubate should not be overlooked. Likewise, if you're not seeing improvement, or especially poor oxygenation or something like that, you need to consider if intubation would be the best for those particular patients. You can always confirm with a blood gas if you're worried about it. But usually, if my patient, if they're impending failure, and I started it, based upon that, blood gas wasn't deranged or anything, as long as they're showing bedside improvement, I'm okay with that. So I don't always get a blood gas afterwards, kind of a judgment call and a conversation you need to have with the physician. So right now, our rate is good, our tidal volume is good, our minute ventilation is high, okay, but this patient's sick. We are reaching our peak inspiratory pressure here, so 18 and 18, so we're good. Total leak is acceptable, 40, okay. We don't want that too tight, you want to leak. Patient trigger. He might have got a couple of time breaths while I'm manipulating it and everything, but this is just how many of the breaths the patient's triggered. Ideally, that'd be 100%. As that starts getting further and further away from 100, all right, we worry, is there leaks going on and the patient's having trouble triggering? The machine can't sense it. Do they have auto PEEP and they're not triggering? Is their rate set too high? What's going on there? And then TIT total, we talk about that a little bit more as we get into invasive ventilation, but that's just a different way of kind of looking at I to E ratio, and some people use that, some people do not. Let's talk about alarm settings here, okay? So alarm settings, alarms are very important, and it's going to be difficult to kind of see some of these alarms that I have set right here, okay? Because the screen's so blurry, so I'll kind of, let me see if I can kind of move that a little bit closer. I don't know if that's better or worse, maybe a little bit better there, okay? So we have the ability to set alarms. Alarms should help us, and not be a burden, okay? So you don't want them alarming all the time because nobody's going to pay attention. If you are, likewise, setting your alarms too buffered out, something bad might happen and you not be made aware. So high and low respiratory rate, okay? What respiratory rate do you want to be alerted to as far as a low rate goes? Now, keep in mind, we do have a set respiratory rate. So if this patient doesn't take a breath for 6 seconds, okay, it's going to kick in and start giving them time breaths, so the respiratory rate will never drop down below what we have set. So it tells you low rate alarm is disabled below set rate. You can set this at 12 or 14 or something like that. Okay, if this patient's respiratory rate goes down to 12 or 14 or low end of normal, do they really need non-invasive ventilation? Or we look at that, or is something bad happening and somebody gave them pain meds too quickly? So I set it higher than the rate, but it doesn't have to be something set crazy high. It's kind of a comfort level. 12 would be appropriate. High rate, okay? When I started, I was trying to get them down below 30, and I'm there. I don't want this thing to honk every single time, so you could set this, generically, most patients, I'd set this at 30 to 35 a minute. 30 be pretty tight, so if you wanted to set it anywhere kind of in between there, likewise, you could set it at 35, and if they hit 35 and sustain, so something's happening, their condition's worsening, it would alarm and let you know that, okay? If you wanted to set it at 30, that's fine too, but once again, it's pretty tight, all right, but you could do so, and it's just touch, turn, touch. You could use a little quick access wheel and the check mark up there too if you don't like tapping so much. High tidal volume, we know these tidal volumes are estimated, they're not exactly measured, okay, and they're going to vary a little bit. I like to know if my patient's getting huge volumes, okay? So when I'm adjusting this, if you set this maybe anywhere 150 to 300 mils above what your current target, so we could set this kind of, let's go 200 mils above. So I'll set this at 650, okay? Now keep in mind, just because you're hitting 650 doesn't mean that's what they're getting. It could be leaks, it could be estimated. It might happen intermittently, okay? But if it's going off constantly and that's how much support they're getting, I would want to go ahead and consider readjusting my settings, making sure everything is good with the mask. Low tidal volume should never be off, okay? I like to generically set this really at that lower range of what you'd like your patient to achieve. Most adult patients, us not wanting them to get less than 300 mils, I would say that would be pretty good. All right. You could also use their 4 mil per kilo tidal volume, but honestly, during initiation, 4 mil is pretty low and not going to be super effective at kind of unloading the respiratory work and breathing, improving alveolar ventilation substantially. All right. So this guy's 70 kilos. If we did his 4 mil, that'd be 280. that's getting down there. So you can set this at 300. If you wanted to set it 100 beneath what your current target is, that'd be fine. I'm going to set it 100 beneath right there, okay? I want to make sure I keep this guy doing good and keep him from getting intubated. All right, so high and low. Hip and lip. Hip and lip, the V60 does this a lot better than the old Vision did, and it makes it very more explicit. The pressure high and low is only referring to our inspiratory pressure, and it's going to let us know if there's a leak that the machine cannot overcome. It is going to alarm these settings, okay? So honestly, we're dealing with pressure ventilation, okay? So the high alarm in this case is not so important for regular ST or anything like that. Might be a little bit more prominent in some other types of things, invasive ventilation and so on. But what this does, if the patient coughs or something happens, it's going to make sure that as soon as whatever pressure limit I have set right here, as soon as it's hit, it would go ahead and stop delivering flow. Okay, so if they cough right at the beginning of a breath or something weird happened, it's just making sure that we don't give an unnecessarily high pressure to this patient. I generally set it 5 or 10 above my current PIP, okay, somewhere, some nice easy number. We can set this at 25, okay? Now keep in mind, be warned, if I set this at 20 and then I start making some changes, as I make changes, if I hit my pressure, it's going to start freaking because it's going to start down-regulating the pressure, okay? So you got to make sure you give yourself enough room to work. So if I had this patient on 10 and 5 and I set this at 15 or 20, as soon as I hit my set pressure at 15, it's going to dump if that's what I have the alarm set at. So you always want it higher than what pressures you're trying to target, okay? And keep that in mind. The machine would honk and let you know, all right? And heck, I'll show you that here right now. Let's look what happens when I set this lower than my eye pressure. It tells me high pressure. Watch what happens. You're going to see this patient's tidal volume start to trend down, and it's making sure the pressure can't go any higher. So I might be making setting changes, but nothing's actually happening, okay? I'm going to go ahead and hit silence. I'm going to hit reset, and you'll see it's going to allow my machine to go back to what settings I kind of had going on here. My low tidal volume alarm is also kicking off, which is good. Lip. Lip is important, okay? Lip is referring to the low pressure on inspiration. So what do you want to be alerted at if you're having trouble reaching our set pressures, okay? I like this really tight, 1 or 2 centimeters beneath what I have set. And the reason you can set this tight without it being a nuisance alarm is because we have this, lip T, low pressure delay time. So low pressure delay time means if he starts talking and he hits my, only 14 or 13 or something like that for several breaths, all right, it's not going to alarm at me. It might alarm low tidal volume or something like that, or high tidal volume, but it's not going to alarm low pressure. It's only going to do it until so many seconds have gone by and that alarm has been continuous, okay? 20 seconds is a good general time to consider setting your low pressure delay alarm for this machine here, okay? So that gives us the ability to avoid nuisance alarms as your patients are talking or trying to do different things. Low VE or low minute ventilation, so keep in mind we are not guaranteed tidal volume, we are not guaranteed minute ventilation on this. All right, so what I like to do, really most patients shouldn't be any less than about 5 liters per minute, total minute ventilation. Most people set that based upon this right here, okay? I generically leave this at 5 liters a minute, or you could get more specific and set it at their 100 mil per kilo per minute value. So this patient, 70 kilos, about 7 liters a minute should be his expected base right there. So you can set it at 5. You should really never probably set this lower than 5 for most adults. Okay, I don't want to come into the room and their minute ventilation is 3 liters a minute and they're dead or something like that. Hopefully all my other alarms are set appropriately. Some people have set that 50% beneath your current minute ventilation. It's really a comfort level. I'm going to set this kind of at that patient's 100 mil per kilo, which would make more sense as we get into invasive ventilation. All right, I would go ahead. If I hadn't done so already, I'd be looking at pulse oximetry and weaning down that patient's FiO2 here. All right. If I wasn't reaching my goal, I would be going up on my patient's baseline. Let's say this patient has worsening pulmonary edema and kind of poor oxygenation, and I'm on 100%. We're going to talk about this more in the application component in class. You can see my patient triggers up to 100% now, so that's good. What would happen? So our only other options to improve oxygenation at this point, okay, would be increasing baseline. Think about this now. My current pressure support, if I do IPAP minus EPAP, is 13. You can hit the button and it also calculate that for you. If I started increasing my baseline pressure to improve oxygenation, you got to think about what that does to my pressure support. Both IPAP and EPAP are set independently. As I bring those closer together, all right, I just messed up my pressure support. Well, what's my pressure support setting responsible for? Work of breathing, tidal volume, CO2 elimination, all right? All these things, it can have an effect on my respiratory rate. So let's say on this patient, I wanted to go up because I'm not reaching my oxygen goal. I can't wean them off 100%. I get an x-ray and, pulmonary edema and things like that. Let's say I wanted to go up on my baseline pressure. And he's treated this like a CHF type patient or something. Let's go up to 8 centimeters of water. Look what happened to my pressure support. It went down to 10. Well, what's going to happen? I hit accept. I made a change to improve oxygenation, and hopefully that will improve and allow me to wean my FiO2 down and or reach my goal. All right. But what's going to take place? My pressure support dropped. You're going to see your tidal volume drop off. As that tidal volume drops off, it's less effective at alveolar ventilation. You're going to see that work of breathing and respiratory rate typically increase again. So what I need to make sure is if I increase my baseline or any change you make, think about what it does to pressure support and ask yourself, did you mean to change pressure support? All right. In this case, no. I was trying to improve baseline for oxygenation. I don't want to drop down here. I'm not going to reach over and make him breathe fast again. All right, but that's what would be happening is work of breathing to get worse. So I need to maintain the same difference because I wanted to maintain my acid base, my ventilation, my tidal volume, respiratory rate, all that stuff was looking good. So as I'm changing my baseline to improve oxygenation, I got to think about the impact my pressure support has. Now, one last thing here you want to be cautious about is your IPAP. I'm not saying you can't go above 20. This machine goes way higher, but you need to kind of pump the brakes before you start going up above 20 centimeters of water. Most patients, you're going to see that their esophagus potentially open at pressures in that 20 to 25 centimeters of water range, okay? And keep in mind, we don't have direct access to this patient's, we don't have direct access to their trachea. So if we're pushing air into the mouth or their esophagus opens up, they could get vomit, and they could have vomit and aspiration. Just to show you again, our leak did go up. All right, by changing these pressures. So once again, I'm still below my 60 goal. If I could get it a little bit more snug, that's great. If the patient was doing okay with it, I'm reaching my pressures, everything looks good, I could kind of maintain the course there, okay? I'm still reaching my pressure, everything's good. I could kind of reevaluate my alarms. I'm still technically okay, but if you wanted to set it just a little bit higher, something like that, set it 5 above, you could. At this point, we would do a full patient assessment. All right, we document all of our findings up here, all of our settings, okay, and kind of go from there. Once again, if you want to get a blood gas afterwards, that's totally fine, but we should be seeing signs of improvement. All right, things to be cautious about. Those patients, you can't get them off 100% oxygen, worsening mental status, inability to get their respiratory rate down despite them getting good volumes and things like that. All right, patients that are becoming combative, somebody that's losing the ability to protect their airway, all those different things would be recommendations to consider possible intubation. We'd like to see mental status improve. We'd like to see respiratory rate improve, vitals improve, all these different things. And once again, we'd like to be able to get down to about 60% FiO2, all right, and still reach our oxygenation goal and everything like that. As we learn more about graphics, once again, we could use RISE to further adjust, but looking at how pressure is building in the circuit up here, everything looks good. I keep monitoring this guy. We talked about how to give a neb if we needed to. All right, he's okay here right now, so we continue to monitor and kind of hope for the best here, okay? I hope that video for initiation and initial titration helps, okay? You could do the same stuff as we kind of move forward and we get into making changes based upon blood gas. A lot of the same concepts still hold true, but for us to do our due diligence for our patient, we really want to try and not get fixated so much on, oh, I'm going to leave them on 10 and 5 and see what happens. We need to look at respiratory rate, tidal volume, work of breathing, looking at that patient, talking to them in regards to making those setting changes and give your patient a optimal chance for success from the get-go. So I hope that helps, and I'll see if I can make another video later on. Maybe we'll do one on an ABAPS or something like that.